Well, thank you to all the attendants. Thank you to Quantel Medical. Thank you to all the companies supporting the Congress, but especially Quantel Medical. Quantel is Quantel and now Lumibird is the main sponsor of this Congress. And you know that they have different devices and very, very efficient devices in ultrasound, in UBM. And so I have to thank Quantel to organize this symposium. We will. The title of this symposium is Innovating in Ultrasound, a 360-degree review from Annular technology to UBM. You have seen that with the same machine, we now can use different probes. And this is a key point for investing in ultrasound. You can invest just by the unit, just by one probe, and add some probes after your current practice. So we have a dense program, but we have a different approach with UBM. I will present this one. Mario is a very high specialist of standardized echography, and he will present his talk. We'll have a presentation from Peter Good on annular technology, and we have the chance to have Yale Fisher. He will present to you the orbital vascularization motion with annular array. So if you want, we can go. My talk in this symposium is UBM in current practice. You have seen during all the sessions that we have many, many different details to see with UBM. This slide is just to show you the differentiation between the approach with OCT on the left and the visualization of the angle with UBM. In our current practice, we have many, many patients refer for narrow angle, and you can observe that we can, when the patients are referred to a clinic, we practice, first of all, anterior segment OCT to get measurements, and UBM to get the anatomy of the angle. You can observe that in this series, we have this number, this percentage of, well, we can see the serial processes with OCT, but we are better with ultrasound, and this percentage of, where is the serial processes? There or there? We cannot tell. And so it depends of the color of the iris frequently. When you have dark iris, you cannot see anything with the OCT, so we have to move to UBM. We can have information concerning the anatomy of the angle, and we can have information post-treatment. We have discussed of the anatomy of the angle. You have in this slide some different situation of anatomic. You can observe that we have an anterior insertion of the iris root, and we cannot see clearly the cellular spur. You can have an insertion of the iris root on the cerebral processes, and this is the discussion with Mario. You can have a very thin iris root on the 360 degree, and you can have these very small cerebral processes. In current practice, we can use a dynamic test of angle closure. We can observe with OCT or with UBM the angle, this narrow angle of this patient with light in the room, make dark in the room, and observe the angle closure. We can take measurements. We have a discussion on many measurements on the globe, but for the narrow angle, we have this kind of tools. We have mainly the AOD 500 on the AOD 750, and we can have this measurement with OCT and with UBM. But in reality, the most important criteria is when you have no opening of the angle. We know that we have all these different criteria for risk of angle closure. We have the anterior chamber depth, we have the lens thickness, the lens vault, the pupillary block, the plateau iris mechanism, the cyst, and the anterior insertion of the iris root. I presented to you this one. You can see some lens thickness very, very high in this case. And for us, this criteria is very important. And now we are looking to the angle, especially in dark condition. And when we have just one meridian for images is not sufficient. We consider that we have to control the angle on the four principal meridians: 3 o'clock, 9 o'clock, 6 o'clock, and 12 o'clock. Plateau iris mechanism is only, for me, a diagnosis with UBM. You can imagine that you have plateau iris mechanism with gonioscopy. Gonioscopy tell you, you have probably, but UBM is better. The three criteria for me for assessing that you have a plateau iris mechanism are there. We have an angle closure. You have no pathway of the liquid in the angle. You have serial processes with an anterior positioning, and we have to consider the extraocular spur. If you have any difficulties to observe the positioning, the anterior positioning of the serial processes, you can draw these curves along the posterior part of the cornea and this curve along the posterior part of the sclera. The intercept of these two curves gives you the positioning of the cerebral spur, and you can observe that these serial processes are on this part of the slide. But we can have differential diagnosis of plateau iris. Sometimes, two times, we have a doctor very expert in glaucoma that sent to us, I think this is a plateau iris. And if you look at this slides, we have no plateau iris. We have just a multicyst situation. The other differential diagnosis is this one, is the anterior iris root. We can use UBM for pigmentary glaucoma and see with UBM or with UBM on the right and with OCT, the response after PI, and the treatment after PI can be followed by this UBM curve, with these UBM scans. You can observe this bowing of the iris despite PI, and so you can assess that when you have this kind of response, we have no perforating iridotomy. One example of PI in front of multicysts, so you have to pay attention to this. And our role as ultrasonographers is to tell to the doctor, to the other ophthalmologist, we have multicyst, but perhaps in this meridian and in this meridian we have no cyst, and you have to put the treatment on the meridian without cyst. Sometimes we have patient refer, I've made a large PI, it seems to be functional, but the angle is not reopening. And so you have a plateau iris mechanism. We can follow iridoplasty. You can observe the effect of iridoplasty. We have to pay attention to treatments that are not at the iris root. We have few patients refer with treatment on this part of the iris, and it's not so efficient. You have to treat just as the iris root. We can follow the filtering surgery, trabeculectomy or deep sclerectomy with the trabeculum on this slide. And UBM can also help us to differentiate nevus and melanomas. You can have nevus is only a gray structure, and if you have a black structure on the iris, probably that could be a melanoma. And UBM can help you in a current practice in order to differentiate we have just a cyst or we have a tumor. The other interest of UBM in tumors is we can get measurements mainly of thickness of the tumor in order to make the follow-up of these patients, because the gonioscopy is not sufficient to follow the patient. And so you can observe 2 years after proton therapy, you can observe this thickness, and you can observe this thickness 3 years after proton therapy. But we can also use UBM in case of luxated IOL. You can observe this implant in the vitreous, but we have had also a few difficulties and few side effects with the phakic IOLs. That makes a very long time we have observed this kind of side effects with a contact between the optic of the lens and the cornea. And we have also the side effects with the anterior phakic IOL, with the contact of the foot plates with the iris roots. So now we have patients referred just to follow these patients in order to take measurements between the cornea and the optic of the implant. This case to show you that we have a unique tool in order to solve this question. Well, these patients are referred to us because he have been operated since 6 months before with pain after surgery. No, we don't know, we don't understand what happened. Can you look what happens? You have the foot plates of the iris completely included in the cerebral processes on this part and on this part. And you can see that we have an oversized implant because you have this distance between the optic and the natural lens that is very high. So UBM can solve you this kind of situation. So you can see that in current practice, UBM is a key point for us in everyday practice for checkup of the patient for the anatomy, follow-up of the patient in case of a narrow angle, and treatment with no good response, and the tumors and the implants. Thank you very much. So this is my great pleasure to introduce to you Mario De La Torre. You all know Mario, but he's a king in South America of standardized A, and so he's the topic of his presentation. Thank you, Mario.
You are kidding, you are pulling my leg. Okay, let's talk something about I am a believer. I am not a fanatic. I think you must use every tool that you have near your hands in order to give the clinical diagnosis or the clinical help to make the diagnosis. First sentence, be multimodal. Now, right now, we will talk about standardized echography. It's a tribute to my mentors, Carlos Soynik and Gerhard Hasenfratz. And I learned from them from Disclosure Medical Director by Lumibird. And the standardized echography was developed by Soynik in the early 60s. I born in the 60s, in July 12th. And I'm the same age of standardized ultrasound. The main purpose is the tissue differentiation, eye, orbital, and ocular and necks. What is that? It's a combination of real-time, standardized B-scan, B-scan is there, and real-time standardized A-scan. Design, with a specific design, in order to achieve optimal echographic localization, tissue differentiation, and optimal measurements. It's one echographic language. There are different languages. I can't say French is better than English, English is better than German. They are different. And you must use it in order to achieve your goals. And for me, it's reliable, understandable, comparable, and repeatable with optimal results. They are the only device with standardized eye scan right now, the Absolute and the Abiso. And the specific optimal design is the instrument, probe, and signal processing for the A scan, and also a standardized technique to perform the examination for both A and B scan. What is a standardized echography? It's an A mode designed for diagnosis. It's a specific probe with a parallel beam. Of course, you can use vector C, and you have an idea, and you have another way to see the things with the standardized mode because you have a specific probe with a parallel beam. They are not similar. They are not the same. It could be similar, but there are different ways to handle every examination. But why? Because standardized is a specific probe with parallel beam, and biometry mode is focused in 23 millimeters, and there's a big difference. And also the ultrasound beam for the B mode is focused. Also, there is a focal sound in the biometry, but in A mode you have another way to do it with a parallel beam. Okay? The parallel beam, compare with the B mode, they are different. The A mode has a specific probe and a specific amplifier and a specific receiver and a specific tissue model just to make the comparisons between two different observers. And all the parameters standardized. This is special characteristics of instrument, techniques, and methods. And they allow the study of echographic signals according to a uniform, stable, and repeatable parameters, compared specifically for more than 60 years. Internal standardization, external. We use the tissue model just to localize the tissue sensitivity. This is the tissue model. And doesn't matter where you are in Bolivia, 4,500 meter heights, in Peru with 99% humidity, And the device functions different because the conditions are different. Conductors, they behave better if you are in low temperature. If you are in Israel, it's a little bit higher temperature than in Finland. But you try to compare the devices. You must have a pattern to compare the signals. And then standardized recovery is different. It's not better, it's not worse, it's different. And then, for many people can tell me that, but I not speak Arabic. But this is a standardized A mode. You see the signals. Do you know what does it mean? No, I don't. Stop. Yes, correct. But you know the language, don't you? I know it. I was driving in Morocco, and I saw that, and I realized this is a stop. Yeah? This is the real combination between the A mode and B mode. You got the same thing, the same information in the different way. Yeah? You can use it, you cannot use it. It's your choice. Yeah? But I am a believer that this is a method. I will try to show you why. Yeah? And then, the main purpose is the tissue differentiation. For me, what is tissue differentiation as well? Is the interpretation of the images that sounds produce when passes through a tissue. And this is correlated with internal structure. And the diagnosis is meant for pre-established patterns. Close your eyes. And here. There are different tissues. They sound different because the structure is different. If you pass the ultrasound beam, you can recognize as well, you can recognize a French speaking English, an Italian speaking English, German speaking, sprechen ein bisschen Deutsch, and then an Argentinian, you can localize the accent. That is the main purpose. Every tumor has his own song, his own music. And this is mathematical. Mathematical is in every place. And then, when you have a voice analyzer, and I have my voice, like a tenor, then you look the spikes that I make. When someone else talk, has another spikes, then I can recognize the person looking the spikes. It's the same. You can recognize the tissues and the tumors looking at the patterns. Okay, this is a very accurate method to differentiate malignant nevus from melanoma, to study Graves' disease. Why? Look, it all depends on the internal architecture of the lesion. If you have an hemangioma, for sure. If you have a carcinoma, esophageal lymphoma, they are different in architecture, they are different in structure. The cells are more or less compact inside, they have vascularization inside, they sound different, for sure. Okay, let's see. And if you know how to interpret that, you have the clue. If you don't know, well, you don't know, you can do everything what you want. Okay, and you can make, of course, a list of characteristics that you have. Amplitude, internal structure, reflectivity, sound absorption, vascularization, etc. It's like if I tell you, you have a tail, ears, nose, and say, wow, it's a duck. Or a bilingual cat also. This is possible. Yeah? Nothing is completely 100% true. Yeah? Okay, you have quantitative echography, topographic echography, kinetic. There's no time to explain everything. And it makes the difference. For sure, I make my practice every day and make diagnosis with B mode 80% of the cases. But I'm not so intelligent. I use, in this 20% that I have a doubt, I use standardized echography because it's a tool and it helps me. Nobody's perfect. And then I use this method just to achieve my goals. Okay, there are differences between the methods and the measurements. There are some papers about that. B-scan is brightness. A-scan is amplitude. I prefer to look in amplitude because I try to avoid the balloon phenomenon. I can do that, yes, of course, but I prefer. It's my choice. Then we are perpendicular, we have linear resolution, parallel being, no focus, etc., etc. Sometimes, okay, everyone can do an examination for tumors. And I have no doubt that you are so expert that you can tell me, even in a figure, even in a video, what kind of tumor are you facing. Because you are expert, you know everything. But no, it's not real. We make mistakes. Everyone makes mistakes. The only person that doesn't make mistakes because he makes nothing. And then, if you use an extra method, and you can see, okay, I make the examination and I see that every melanoma that I see has low reflectivity, this is compact, has vascularization. Okay, you must be blind to see this is not true. Yeah? And also, if you find that hemangioma has high reflectivity, have a signal in that way, and the carcinoma has a V shape, and you repeat it 60 years, that history, and almost always doesn't exist. Yeah? And then you have a good correlation, you can use it, and it's good. A demonstration can see, okay, if I use this suggest malignant melanoma, I can make a differentiation. Yes, of course. In video, in figures, okay. Also with the nevus, okay. Also in little nevus, you can see. And if you make the proper examination in the proper area, with the proper distance or height of the tumor, you can make it. Okay. We also see, as you well know, that we have exophytic and endophytic melanoma as well, and we have the same echo in the, we can see the sclera just in the middle, and then also with retinoblastoma, very irregular structure with calcification inside. The melanocytoma is pigmented but high reflective. Then the carcinoma, even I can see that he has the form from carcinoma, it's nodules. I can see the V shape, and you can see this. And you know what? You can release it also with artificial intelligence, and we are doing that as a project. If you can do that, let's see, it works. And then choroidal osteoma is also possible, and then macular pseudotumor. Sometimes they came with a diagnosis, there's a melanoma, and it's not a melanoma, it's a macular degeneration. And then orbital tumors, the same thing. Sometimes it's difficult. I can't, believe me, I can't do that. I'm not so a good expert to like only seeing that I can say that's a tumor. No, I use another because I'm not a super expert. I'm a normal human being that has limitations as everyone. But if I do that, I can clearly see the pattern for the sound passing through the tumors. Then orbital tumors, we can see lymphangioma, metastatic carcinoma, lymphoma, hemangioma in the adult, etc. And also I use it for differentiate vitreous detachment and also retinal detachment because retina is smooth. When you send an echo to the smooth surface, you get all the reflection to your proof. If you have vitreous, that is not as coarse, you get the reflection in different scattered, and it's difficult to say. Sometimes you have problems, for sure, and you can use something else, and you can get better results if you are trying it. Must be trying, that is the problem, but in gray disease also, we can have a measurement of every muscle, even the obliquous, the medial rectus on everyone, and the optic nerve pathology, intraorbital. We can also see the optic nerve meningioma. Here you can see so clear. And also we have correlation with the histopathology, and we can see the fasciculus optic in the center, and the other part of the tumor, the meningioma, with the psammoma corpse inside, and we can correlate it. Sometimes in B mode, we see the optic nerve is dilated, but we have another view, another point of view. When you get married, you get the house to your fiancé, and you see the mother, you see all the family, and you decide if you get married with the family, because heredity is very important. You must take all point of view to make your diagnosis. Melanocytoma as well. Conclusions, please. What is the message? Is this the perfect method? There is no perfect method. But before ordering more complex and expensive ancillary exams, I think the standardized ultrasound A combined with B scan should be the first choice. It's a quick test with a good cost-benefit ratio. This is reported by an expert who knows the ocular pathology as well. And thank you. Gracias. Merci beaucoup.
So you can see that ultrasound is not only ultrasound, it's also passion. Thank you. So now I have to introduce to you Peter Good for the talk on the annular technology in ultrasound of the optic nerve, posterior sclera, and orbit. Peter.
So thank you very much. So I'm going to introduce you to the annular technology devised by, or used practically by Quantel. Their 25A probe, which, so the following slides hopefully will see how we can use it in the clinic. So I'm not going to just concentrate on the sclera, optic nerve, and orbit, but I'll show you how we can use the different settings on the probe, on the software, to actually fire up different parts of the annular probe to look at different parts of the eye. So it has an improved lateral resolution, and you retain the axial resolution as you have with the Aviso 20 megahertz probe. So if we look at the globe, this is obviously with a standoff water bath, we can see that we have a greater depth, and that's increased by 70% compared to conventional probes. And you can see that we are able to see the whole globe, all of it more or less in focus. So how does it basically work? Well, you have 5 annular transducers within the probe, and when you fire up different transducers, fire up is a very bad term, but that's the only one I know that I can think of, you basically will look at different parts of the globe. So the more 4 and 5, you start to get towards the orbit. The orbit, in fact, is a feature seen on a 15 megahertz probe, but it's the main ones we use are eye, vitreous, and retina. So eye is basically the first 2 transducers, then vitreous 3, and then 4 and 5 looks at the retina and orbit. So let's look at the eye setting. So we can see that you get a very nice image of the whole globe, more than the 50 degrees that you get with conventional 10 megahertz, and certainly much more than you get with a conventional 20 megahertz. We get a nice image of the lens, and you can see pretty well the whole lens, not just the sort of small sector of the lens posteriorly. And you can see the lens capsule, clearly in this case, intact. Obviously, with the eye setting, you see less a definition of the posterior segment and the orbit. Using the vitreous setting, we get a very nice image of the vitreous. And in this case of endophthalmitis, we can even see an inner limiting membrane detachment. The retinal setting is the one we use mostly for tumors, sclera, and the orbit. So here we can see a melanoma with some scleral excavation or scleral infiltration. So you see the lesion is infiltrated into the sclera. If we have a lesion that extends into the orbit, we would see that very clearly as well. I don't have an image of that on this talk. We can see very well vascularity within the within lesion. So here we can see blood very clearly within a tumor. And we can see also subretinal fluid very clearly. This is always difficult sometimes because subretinal fluid is such an important diagnostic factor for MM, and often is only seen using OCT, but here we can see it with the ultrasound also. And you can see the difference when you compare it, for those of you who have a 20 megahertz probe, either with LX or with Aviso or Sonomed. You can see much more into the orbit. So you can see the different retinal layers, the choroid, sclera, and into the orbit. Here we have an MM with a UBM. It's the same MM as this one, in fact, but we did a UBM just to make sure there was no ciliary body involvement. Here we see metastasis, so it has the typical bilobed appearance. This time the primary is in the lung. Tomorrow I'll do a talk on tumors when I include the A scan as well. So you'll see some more A scans tomorrow, you'll be pleased to know. Something to look forward to over your breakfast. And here we have an interesting image where you can see this patient who's had silicone oil removed. And as Yale mentioned, you always end up with some remnants. But you can see that there is a pre-retinal fibrotic membrane here, but also a very shallow retinal detachment. Important thing with this scan is that the surgeon wanted to know whether this retinal detachment was going to continue. Was it going to get worse? This patient, this is their only eye. They had already had silicone oil put in. They didn't want to do further surgery. And the surgeon had used laser to seal the edge of the detachment. So he wanted to make sure there was no subretinal fluid extending behind it. So we can very nicely see with this with this scan, the laser scars at the edge here. So we know that the subretinal fluid is not extended beyond the treated area. Here we see a patient with a Barvelt tube located behind the eye, and we can see that there is a little bit of choroidal effusion. The patient was a long-standing glaucoma patient, and you can see the grossly cut disc. So the information we have from the scan involves the disc, it involves the choroid, the sclera, and we can see the Barvelt tube in the orbit. This patient has a painful eye. We saw not just this is a thesical eye that is, obviously we have detached retina, but also we see that the pain is caused by the patient having developed scleritis. Here we see a coloboma in a patient. This is a 3-month-old child. I use a lot of ultrasound in pediatrics, and on this very young baby, through the eyelid, what is the beauty of this scan, this probe, is that with a conventional 20 megahertz, you either have to go directly onto the sclera or you have to press quite hard to get a good image through the eyelid. And what is the beauty of this probe is that with a very light touch, you can get a superb image of the whole globe and the orbit. So it's very useful for young children because obviously they're not going to tolerate having a probe put on an open eye or a heavy-handed push on the globe. And so the only alternative would be to use anesthetic, which we don't want to use, or any other sedation. Here we see a hemangioma in Sturge-Weber syndrome, and we can see an extrascleral extension of the hemangioma into the orbit. This patient with VKH has choroidal effusion and shallow retinal detachment, and we can see the different layers of effusion and also vitreous cells in one image. So we don't have to use different probes to get image of the vitreous, to get image of the sclera and the choroid and the retina. We can get all of these images with one probe. Here, a patient who has, again, a very small extrascleral extension. You can see just here in a choroidal nevus. So you can see the gap through Brooks membrane, and you can see the extrascleral extension quite clearly. Definitely not a blood vessel. And so very nice image of the whole of the anterior chamber. Sorry, the whole of the anterior orbit. Here, choroidal osteoma. Nice detailing of the little bit of calcification, a very small osteoma. The nice thing as well is as with other 20 megahertz probes, you get a much better image of drusen, buried drusen. The problem with drusen is it doesn't always appear as a large hyperreflective area within the disc. Particularly in children, the drusen is often uncalcified in its early stages and becomes calcified later on. So very small areas of drusen don't always show up, certainly not with a beep 10 megahertz or 15. And with the 20, you do see these little tiny areas of drusen, which helps make the diagnosis. Here we have a patient, this is a 5-year-old child with uncalcified drusen. So the drusen is very much on the surface of the lesion. And you can see this with OCT, I think, very well. But the problem is in a 5-year-old trying to get them to fixate, abduct their eye so you can get an image of the disc is not very easy. And we see here two things we need to know. We can see the uncalcified drusen. We can see the nerve fiber layer is not elevated. And we can see that there is no fluid in the nerve sheath. One comment I'd like to make is that fluid in the nerve sheath does not indicate papilledema. It doesn't indicate meningioma. It can do, but if you get it, it doesn't mean you have got pathology. So it's important to remember that because I think when there's no fluid, that's a good sign that there's no papilledema. But if you do have fluid, it's not always an indication of fluid that is pathological. Here we have multiple areas, so multiple pathology if you like. Here we have macular edema. Here we have scleral thickening, fluid distension of Tenon space, and we have a small area of drusen as well. So you can see multiple things going on within the posterior segment. Another case of posterior scleritis. We can see Tenon space very, very well and thickening of the sclera. Not all cases of scleral hyperreflectivity, of course, are osteoma. We see a lot of cases of scleral calcification in patients with parahypothyroidism, where the scleral hyperreflectivity is in both eyes, usually supratemporally, and usually one eye more than the other. So you can see both examples of the calcification there. This is interesting. This is a patient who had a nail go through their eye. And we can see a vitreous incarceration. So we can see the track of the nail through the vitreous. It has perforated the sclera. And you can see there is hemorrhaging into Tenon space. And when we use the 15, we got a very good image. But the 20 just gives it a bit more detail. So we can see actually that what happened when the nail came back out again, actually some tissue plugged the sclera, so the eye did not become hypertonic. But a lot of information there from the one probe. We get the whole of the vitreous, we can see the perforation through the sclera, and we can see the hemorrhaging into Tenon space. This is actually an orbital setting, but it's actually, in fact, the retina setting, because I said the 15 megahertz is the one with the orbital setting. But if you use the retina setting, you get very nice orbital images. Here we have an optic nerve glioma. So you can see the structures very clearly around the nerve. Here, orbital inflammation, which I showed earlier. Again, we can see the sclera, tenon space, and the anterior orbit. And here we have a varices, and you see during the valsalva, you see the distended blood vessel and of the varix, and then after valsalva, it gets much thinner. Just another picture of it there. It gives very nice images of the extraocular muscles. These are normal muscles, lateral, medial, and inferior. In thyroid eye disease, obviously they get thicker, and we can see that. This was an interesting patient who basically had macular degeneration and proptosis. The problem was that her vision was much worse in her right eye, where she had slightly more macular degeneration. Although from OCT, you couldn't really tell which was the eye with the more macular degeneration. So it became very difficult to determine which eye had the thyroid eye disease in terms of thyroid optic neuropathy. So when we did the scan, we saw the macula. Here we have the macular degeneration. And here with the medial rectus, we see that in the right eye, with the poorer vision and suspected to have optic nerve compression, we see that the muscle is not nearly as hypertrophied as in the left eye. So in fact, it was the left eye with the better vision that had the thyroid optic neuropathy. And this was confirmed by ocular electrophysiology, although even the VEP was misleading because, of course, it gave the indication that the worse VEP was in the eye with the more extensive macular degeneration. And also in the same eye, you could see there was some fluid distension of the nerve sheath, in this case pathological because it wasn't in the other eye, and also a distension of the superior ophthalmic vein, which you can also see can be secondary to compression of the posterior orbit. Here we have a case of optic neuritis, so we can see the diffuse enlargement of the nerve. And here, this is something I use a lot in children to look for either optic nerve hypoplasia or optic atrophy. So this was a child, a young child, very difficult to get a good view of the fundus. Disc pallor was suspected, but in fact, you can see here that the optic nerve in the right eye is very small, 1.7 millimeters, 2.2 millimeters in the other eye, so atrophic optic nerves. Papilledema in this case, we see the elevation of the nerve fiber layer as well as the disc and fluid in the nerve sheath. And I finish with this slide, which is, I think is an amazing slide because it actually is effectively an OCT provided by ultrasound, because you can see the different layers. You can see the inner nuclear layer. You can see the probably the outer nuclear layer. And here is the choroid, and here is the sclera with the tenon space. This is of no use clinically, but it just shows of the power of modern ultrasound, how we are getting better and better images of the posterior segment, and who knows where it will take us in the future. Thank you very much.
Well, and now we will go to the presentation from Yale Fisher, orbital vascular motion with annular array. Yale from New York. Thank you very much.
I wanted to do two things. I'm going to use the microphone, but I probably don't need it. I'm not as good at starting a religion as my former speaker was, but I would like to try. There are two things I want to talk about besides what my lecture is about. The first is the most important for your residents and fellows, or if you're around for endophthalmitis, because it's been mentioned a few times. What hasn't been mentioned is that it's really important to do an ultrasound before you do a tap and inject. That's really critical. How many times have you heard a resident or a fellow say, I did a tap, but it was a dry tap? I hate the word, because it means that they didn't get fluid. And depending how aggressive that resident is with creating suction with a syringe, you have a lot of problems on your hand. I've trained every resident. I said, look, you're going to stick a needle in the eye, just put the ultrasound probe in the area first. Make sure there isn't a choroidal there already. Make sure that when you pull that syringe, you're going to get fluid. Because with a UBM, or ultra-high frequency ultrasound, you can put it right in the area you're going to make an injection or take something out or hope to take something out, find out where the pus is versus where the fluid area is. And I've had images all along. I didn't bring them with me today, but it hasn't been mentioned yet. And I think it's really important because a tap and inject is usually done by someone in a clinic quickly on a weekend. It's always a holiday or something like it. And I'm frightened to death that they're going to put a needle into the suprachoroidal space and pull. And that's what creates a problem. There's a sudden hemorrhage, and everybody says the eye couldn't be saved. That was one thing. So I'm done with that now. I made my point, I hope. The second is three-dimensional thinking. I glossed over it. But even for all of us, to get an image on the inside of your eye, as I use ultrasound, and I said there are many different uses. I don't do tumor work except when I'm pressed to. So I have very little need for any type of ultrasound other than what I'm doing with vitreoretinal surgery. I need to know what's going on inside that eye. To do that, you'll be surprised even at yourself, and I am all the time. As I'm doing the ultrasound, to make sure I remember what's the top of the screen, what's the bottom of the screen, what's the left, and what's the right. It's so easy to forget because it's so easy to do. You don't realize that you are uncovering things as you're doing them. And just take a moment as you move the probe around to be sure that you recognize where you are registering that screen. Are you nasal? Are you temporal? Are you superior? Are you inferior? And remember, I never shoot through the lens, ever, except when I have to, okay? So I'm always asking the patient to look down. I keep their eyes open so they don't get frightened. I notice where my white dot is. It's usually towards the nose from above or below. And then I recognize what's supratemporal, what's supranasal, where am I? You'll be surprised how often that is. I do it usually starting with a retinal detachment that's complete, and I ask a resident or fellow, I'm going to give you the diagnosis. The diagnosis is a total retinal detachment. I'm going to put the probe on the top of the eye and shoot towards the inferior part of the eye. I want you to draw a screen. You can do it here if you wish. Tell me what the image will look like if I cross-section that retinal detachment. If they can't do it, how the hell are they going to do it the other way? Look at the screen first and then tell you the diagnosis. If they can't even tell you what the screen looks like, if you give them the diagnosis, I'm almost sounding like you now. I'm going to start my own religion. I've decided my religion is gig. God is gravity, and gravity is God. That way you don't have to hate anybody else. Gravity affects all of us, and it's a simple religion. I have 4 followers so far. That's it. It's a very cult-like religion. I ask my fellows and residents and anyone that will come near my office, tell me where you are. What are you doing with that probe? Because we're only getting a slit. And the second question is, what's the resolution of the probe that you're using? Can you see the things you think you can? I'll bet you everyone in this room, how many people use a Heidelberg? Just by show of hands. How many people use an OCT called a Heidelberg? Okay. And I ask people just routinely, What's the axial resolution of that Heidelberg? And everybody says 6 microns, because that's what you're told to say by the salesman who wanted the $175,000 that you paid for that machine. Is it 6 microns? Axially? Okay, it can be in a perfect situation. Most of the time it's less. What's the lateral resolution? Everybody says, I don't know. There's a reason they don't tell you. And the reason is simple. It's the same reason that we get for the ultrasound, because that's how they figured out how to do OCT. It's by the shape of the beam. The width of the beam determines your lateral resolution. So, what's the lateral resolution of a Heidelberg? About 25 microns, maybe if you're lucky. That's why you don't see cells. You don't see the rods separated from the cones, because they're smaller. And the beam is narrow, but not that narrow. Lateral resolution is always worse than axial resolution. Any photographer will tell you that. And it's usually a factor of 3 to 4. What's the lateral resolution and axial resolution of the instruments that we're using? We're using ones that are improved with a 20 megahertz. 15 gives you good, 20 gives you better, 10 gives you less. Axial resolution, probably on a 20 is somewhere around 85. I'm not exactly sure that's accurate, but it's pretty close. What's the lateral resolution? 3 to 4 times worse. So, how important is an axial and lateral resolution knowledge? Really important if you're looking for small tears. Now, I'm going to leave this alone. I've talked about what to do with endophthalmitis. To make sure that you really know what three-dimensional thinking is, it takes a long damn time to get good at it. And I'm good at it now. But I wasn't good at it for a long time. But I thought I was. I want you to challenge yourselves. Okay, now we'll talk about annular array. I'm sorry to get off on it, but I'm telling you right now, it's the hardest damn thing to learn. And once you got it, you've got it. And you say, oh my goodness, how much have I missed? I do that every day. I'm in fear of making a mistake constantly. But I love ultrasound. Okay. I didn't realize I was that bold. Oh, well, what can you do? Okay, I'll bring it up. It's dangerous to look at yourself. So they wanted me to talk about 2 things. The first and most important thing is I don't get money from anybody. I'm not supported by anyone, and I paid for my trip here, and they can't pay for my hotel. I told them if they want to pay me, it's $1 billion. That's my price. I'm unethical above $1 billion. So far, nobody has given me $1 billion. Anybody? No, there's nobody. So we're going to talk about annular array, and you've seen a lot of these pictures before, but I want to focus on the patient that I showed you before when we get to it. So I don't have any financial interest, and you've seen all this. I'm going through it quickly because I want to get to that one patient. And I did all this beforehand. This is what I wanted to show you. Real-time movements. How important is that? It's really important. You can have 2 kinds of real-time movements, in my opinion. You can have induced ones, and if you watch the picture up on the right, I've induced that motion by asking the patient to move their eye. And that characteristic movement of eregmatogenous retinal detachment with or without folds will depend upon what the folds have done. Okay? But there are other movements. There are spontaneous movements. Thermal. Look at the picture down on the left-hand side. Still gives you nothing. Real time tells you it's a 12 to 6 o'clock picture because you're going to see a current created by the coolness of the cornea and the heat of the iris. Okay? So that's thermal. What about specific gravity? Well, you saw it already. Those little emulsified oil bubbles. I don't know how many people understand what an emulsion is. An emulsion can be stable or an emulsion can be temporary. The emulsions that are temporary are like when you mix oil and vinegar and you shake it up and you leave it alone for a while, it goes back to 2 layers, right? What's the most common permanent emulsion that everyone in this room uses periodically in the kitchen? Mayonnaise, correct. Mayonnaise, if you want to speak like he does. But it's mayonnaise, right? It's a permanent emulsion. So what makes silicone oil so dangerous? It's inert, but inert does not mean non-injuring, okay? Here's the problem. When you put silicone in an eye, it's a single bubble. And it wants to say a single bubble. But if the patient wiggles their eye, bubbles will come off of it. But when they sleep, it will go back into it if they are not emulsified. Emulsified means a fat layer has been put around the silicone oil bubble. And once that starts, it's over. I don't care what you do. And it usually happens in PVR cases when the retina has been operated on a lot and there's a breakdown in the barrier between blood and brain. Fat leaks out. And when that silicone bubble, with the patient's movement of their eye comes off, it gets coated with a little bit of fat. And now the surface tension has been changed. The little bubble can no longer get back into the mother bubble because it's coated in fat. And that keeps happening and happening forever whenever they wiggle their eyes. Ultimately, when it gets down to about 30 microns, the body no longer sees it as a bubble of anything, and it can go anywhere, and it does. It goes into the retina, it goes into the choroid, it goes through the sclera, it goes into the brain, it goes anywhere. Why do you think they're not using it on transplants for women's breasts anymore? Because they can't get the stuff out if it breaks. It emulsifies because it's filled with fat. If there's no fat, you're not going to get emulsion. So when you see the silicone oil bubbles after anti-VEGF injections, those are not emulsified. That's the lubricant put on the needle or the syringe. You inject it, and you will see it by ultrasound every single time. But I'm not worried about those because they're stuck in the form vitreous. What I'm worried about are these suckers, because they're going to go anywhere, and they go by specific gravity. Then the last part is really the first part of what this talk was supposed to be, and I'm sorry to get off on it, but I just wanted to express myself, if you didn't mind, because I think it would help you clinically, and that's what I am. I'm a clinician. I am not an academician. I do a lot of academic work, but I'm a clinician. And the orbit is very, very complicated. It's got nerves, it's got lymphatics. By the way, there's no lymphatics inside the eye, but there are in the orbit. And it's got all kinds of blood vessels, so it's complicated and variable. But the motion I'm going to talk about is arterial. Believe it or not, you can also see the veins. We've seen that already, and that's the patient I want to talk about, but not always. So what are normal vascular movements around the optic nerve? They're easy to see, they're intraconal, and they're usually subtle. The abnormal ones are caused by some embolus that backs up the system, or tumors that have arterial motion and flow in them, and the AV fistula that I showed you. So with the higher frequencies, we get better resolution. We're going to see more movement. We can set the focus to the retina. We can get the patient to be very careful and you to be very careful. You're going to find out how much tremor you have. Try to hold an ultrasound probe still. Try it. Just try it. One hand and trying to hold the patient's head with the other and tell them, don't move your eyes. Really? Good luck. It's hard. That's why I take movies, so that I can look at it at another time and scan it for the abnormalities. I do APs and transverse and radial and quadrants. I've talked about it. We look in the intraconal areas, and we do careful observation for movement so that we know when we don't have a normal movement. So this is the patient I showed you before. You can see the retina lying on the choroid and on the sclera is right behind it, and you'll find that with this probe, you're going to see fluid in a lot of people that don't have scleritis because it shows up. The resolution is better, so a thin layer of fluid in tenon space that you know was there all the time Every time you passed a muscle hook in your life around a muscle, you said, gee, that's really easy. Must be liquid. Must be some liquid. There is. There's some liquid in my own when I do myself. And normal motion just kind of looks like this. There's just a little bit of beating of the cardiac rhythm. And I never used to see this routinely anymore. I mean, before when I just had a 15, maybe I would see it occasionally. I don't know, maybe I didn't look for it. But when they get bigger, you can obviously see them. And some of them are larger in the orbit. Just have to get to know what you're looking at. Some are easier to see than others. You can do focused movement tracing, and I traced this one I showed you before into the optic nerve. And I just watched it disappear. It was the ophthalmic artery for that patient. Are we seeing the whole orbit with ultrasound? No. We're seeing about 12 to 15 millimeters behind the eye at best. You want to go behind that, get yourself an MRI. That's part of this multimodal imaging. It's not ultrasound's failure. It's just that we're limited. How long does it take sound to get in and get out? They have to do it before the next ring. How many times does it ring? How long does an ultrasound probe ring? Maybe 80 nanoseconds, and it listens for 300 milliseconds. So it's listening a lot more than it's sending. And it's happening 4,000 or 5,000 times a second. I'm surprised we get any image, but we do. It gets exaggerated when you have a central retinal artery occlusion, as you can see here. And if you watch carefully, those vessels are trying to pump that thing further, but it can't because it's just stuck at the cribriform plate. So it backs up the system. And this is the one I wanted to show you. This is the lady who came to me in 2017 and 2022. There was nothing in her eye. She just had eye pain. She said, my eye hurts me. I thought she had scleritis. But I did an EDI OCT. Yes, there were things there. The vessels were large in the deep choroid, but I just thought she might have central serous. And it wasn't until I saw that annular array and the beating of that superior ophthalmic vein. That's a vein, not an artery. What in the world is it doing with a pulse? I'll tell you what it's doing. It came from inside her head. She had a carotid cavernous fistula. It was dural mostly. It was not a direct. It was an indirect. There are 4 ways to see a carotid cavernous fistula. Direct means it comes from the internal carotid. All the others, it comes from the dural branches of either the internal or external carotid, but somehow or other they broke and got into the sinus. And when they get in that sinus, they fill that vein up. How long can it last? I don't know. The bottom one I showed you already, but this is what I didn't show you this morning. This is the DSA, digital subtraction angiography. And you can see that vein light up. I called the neurosurgeon. He saw the patient right away. He wasn't even really worried about it. It's the first one that I had seen this way, and he didn't know anything about ophthalmic ultrasound. I said, hey, listen, don't you want to do this? He says, no, I can just stick a thing in her femoral vein, femoral artery and go up to her head. I said, this would be easier for you and a lot less invasive. He said, nah, it's interesting. I couldn't convince him to do this. But this is the pre-embolic picture. And then he embolized her. Anybody know what those coils are made of? Anybody? Just shout it out. Platinum. They're made of platinum. It's a big deal. Not for these guys. I asked him, I said, how many of these you see here? He says 25. I said, you want to get this ultrasound machine? He said, no. He said, I'll just stick another thing in I said, okay. Good. Not to me, I hope. So then he embolized her. And this is the picture afterwards. It looks a lot more normal even if you didn't know anything about DSA. And I've learned all these branches now myself. But if you think I knew them before, I would be lying. I don't lie. So this is the post-embolic thing. He cut down most of the motion, almost all of it. I think we saved her life. An ultrasound of an orbit saved this woman's life. All right. These are the patient that I showed you this morning also who had a Wyburn-Mason syndrome, and not all of them react. I'm done with this. Annular array is really helpful, and I'll go through it quickly because I want to get to one last thing and I'll stop. And that's measurements. Boy, do we have a problem with measurements. And mostly it's because of resolution. The better your resolutions, the better your measurements. So I don't really care whether you measure it one way or another. Just write down how you did it or put it on the picture. Somehow or other, the next person who comes along when you're out in California or Paris right now, who's doing my work at home? And if that patient comes back, they have to get reproducibility. So we're associating numbers with physical quantities. And there are many considerations. I won't even go over all these images and capture and workflow and display. Whether you're perpendicular, you're not perpendicular, the resolution, the contrast, how do we get anything? Well, really, we're in the area of digital measurement and control, axial resolution, which is related to probe frequency, and lateral resolution, which is equal to the beam width. And then we have to worry, can we get volume measurements? So for me, it's a clinical application. It's a measurement of objects that are familiar with you that will help you. Start doing the optic nerve cup and take an Optos and see how good your measurements are versus the Optos. You can't tell the rim so well, but you can tell the cup. Once you feel comfortable with that, then you'll feel comfortable following patients, because what's important is reproducibility and change over time. That's what the measurement means. It doesn't mean one way is better than the other, and I'm not out to prove anything wrong. Yeah, I don't do quantitative A-scan. But I want to know that what I get is it growing, is it changing, is it doing something? That's fine for me. And there are many different techniques, and my preference is B-scan with simultaneous A, but I have no problem with anything else as well. I think it's better performed by the same experienced person with the same device on the recorded parameters. So measurements are B-scan localizations for me with an annular array and a software measuring package for axial length, and lateral measurements, which are really up in the air unless you do it exactly the same each time. Your lateral measurements are not going to be as good, and certainly probably not as good as what the people think. I showed you one this morning. Let's talk about this mass for a moment. Tumor, okay? You saw the movie. There's a little neurosensory detachment. I pick and choose where I'm going to measure, and then I'm going to try to get back that same image before I measure it again. And once I freeze it, I have to decide, am I going to measure from the top of the retina to the beginning of the sclera, or in this case, the top of the mass right to the beginning of the sclera, or am I going to include the sclera? Write it down. What did you do? Then you got it. No one can take that away from you. So this happened to be a metastatic case, and then I did a en face OCT on the left to look at the venous supply underneath the retina. These are beautiful images. And we also did an ICG on the right. And then I measured this with those two techniques and matched it to the ultrasound techniques, and they come out pretty close. That's what you want. Multimodal imaging matched. If there's something wrong, then there's something wrong. Go back and look at it again. That's what I do. So now I'm done. I've given you my religious outlook. We've worked on endophthalmitis and three-dimensional thinking and a vascular approach to improve B-scan with annular array. I believe in them. I'll change in a minute if you give me something better. Have a great day. I've enjoyed it.
Thank you. You have many information in this symposium. Thank you to Quentin. Do you have just one or two questions, but we have not many time? We can discuss at the coffee break if you want, so we can go to the coffee break, and the next session will be in 20 minutes, ultrasound and OCT. And I have to give you information concerning the gala dinner. We will have a bus that will be in front of the Novotel at 7 p.m. And if not, you can go directly to the boat in the Port de la Conférence. You will have information at the desk. Okay? Thank you.